Hematopoietic stem cells of bone marrow give rise to myeloid stem cells and lymphoid stem cells. Acute myeloid leukemia is a cancer of the myeloid line of blood cells, characterized by the rapid growth of abnormal cells that build up in the bone marrow and blood and interfere with normal blood cell production. The malignant cell in AML is the myeloblast. In normal development of blood cells, the myeloblast will mature into a white blood cell, such as an eosinophil, basophil, neutrophil, or monocyte. The myeloblasts in AML are abnormal and do not become healthy white blood cells. As the number of these cells increases in the blood and bone marrow, there is less room for healthy platelets, red blood cells, and other white blood cells. This may lead to easy bleeding, anemia, and infection. The leukemia cells can spread outside the blood to other parts of the body, including the brain, spinal cord, skin, and gums. There are different subtypes of AML. In 2016, the World Health Organization classified AML based upon a combination of morphological, immunophenotypical, genetic, and clinical features. They are AML with recurrent genetic abnormalities, AML with myelodysplasia, related changes, therapy-related myeloid neoplasms, AML not otherwise specified, myeloid sarcoma, and myeloid proliferations related to Down's syndrome. The French, American, British classification of AML is based on the type of cell from which the leukemia developed and its degree of maturity. M0, acute myeloblastic leukemia without maturation. M1, acute myeloblastic leukemia with minimal granulocyte maturation. M2, acute myeloblastic leukemia with granulocyte maturation. M3, acute promyelocytic leukemia. M4, acute myelomonocytic leukemia. M5, acute monocytic leukemia. M6, acute erythroid leukemia. And M7, acute megakaryoblastic leukemia. Weight loss, physical signs of anemia, including pallor and a cardiac flow murmur, fever and other signs of infection such as lung findings consistent with pneumonia, thrombocytopenia can cause petechia, dermal bleeding and ecchymoses, and leukemic infiltration of the organs can result in hepatosplenomegaly, lymphadenopathy, and swollen gums are common clinical findings of AML. There are several laboratory investigations to find acute myeloid leukemia. In full blood count, white cell count may be normal, elevated, or low. Red blood cells may be low, revealing anemia, which is usually normocytic and normochromic. The platelet count may be low. Peripheral blood smear may show myeloblasts, which are immature cells with large nuclei, usually with prominent nucleoli. Auer rods may also be seen. Lactate dehydrogenase may be elevated due to increased cell turnover. Uric acid may be elevated due to increased cell turnover. A bone marrow biopsy is required to stage the disease. The percentage of blasts determines chronic versus accelerated versus blast crisis. Flow cytometry may be performed with peripheral blood or marrow aspirate. It is used to identify circulating myeloblasts by characteristic patterns of surface antigen expression, such as CD34, CD13. There are several known risk factors for AML. Being exposed to a significant level of radiation, exposure to benzene, which is found in petrol and cigarette smoke, certain blood disorders, such as myelodysplasia, myelofibrosis, or polycythemia vera, and certain genetic conditions, including Down syndrome and Fanconi's anemia, are known to trigger the genetic mutation in acute myeloid leukemia. Hope you learned something valuable in this video. Don't forget to like and share this video. Thank you for watching. Let's meet in another informative video like this.